So when you do psychopharmacology or medication, they always want you to say if you work with any particular pharmaceutical companies and that kind of thing, to see if your talk is biased anyway. So I don't have any relationships with any pharmaceutical companies or any other companies. And they also like you to say whether the medicines you're discussing are formally approved for use in a disorder by the FDA. And in autism, there are two medicines that have FDA approval. One of them is risperidone, and the other is aripiprazole. And they're specifically approved to treat irritability, which the FDA defines as aggression, self-injury, and severe tantruming. So no drug in the world is FDA approved to treat the social impairment, the language impairment, the ritualistic behavior, just really aggression. And only in autism. They're not approved for Asperger's disorder or PDD-NOS, and they're not approved for use in adults. So that doesn't mean we don't use medications off-label. In other words, medicines that aren't formally approved for use in autism, but that may be helpful for symptoms in autism. So I have a couple of slides with regard to the kinds of things we like to do before we even get around to thinking about a medication. And I'm not focusing on medication because it's the only way to go. I'm focusing on it because it's the thing I know the most about. We have caregivers from multiple disciplines, and that's really an advantage. Most autism clinics in the country are driven by one discipline. Either they're all psychiatry or all neurology or all developmental pediatricians. And here, the real value is that you have these people with different perspectives, and we question one another. I learned things in Dr. Neumeyer's talk today that I didn't know before that will help me be a better doctor. So diagnosis is important. We see lots of folks referred to us that with a diagnosis of an autism spectrum disorder that we don't think has an autism spectrum disorder. We can imagine why somebody gave them that diagnosis, but if you're really looking carefully and going through things, we try to say what the truth is. And so there are times when there's a person that has that diagnosis, but we don't feel that it's accurate, and we would tell people that if we thought that. It's always important to look for identifiable physical causes of behavioral symptoms before you move to using psychopharmacology. That's an important point that you want to remember. Many of our colleagues in medicine, they don't even think that if you have autism, you could have gastroesophageal reflux disease. They do if you sit them down and you talk to them about it, but on first glance, they really don't. I'd say particularly adult doctors, because pediatricians are a little more familiar with dealing with kids with behavioral problems, but many adult doctors would, I think, be amazed that a person with autism could develop cardiac disease or something, because you just don't think about it that way. But it's important that people begin to do that. Neuropsychological testing, I think about that with regard to trying to determine somebody's level of cognitive ability. You could say IQ. That's another very controversial area. If you look at a 30-year-old adult male with autism who can't speak, how do you know what his IQ is? And should the IQ test that they use to test us be the same one that is used to test him? So many people in the world would just assume if an adult can't talk that they have some degree of mental retardation. But I think it's important to keep an open mind about that. If you talk to the parents, they'll tell you that that's absolutely not the case. But in the way the world thinks about intelligence, it gets tricky. Dr. Neumeyer talked about genetic testing, and that In some cases, you'll find a cause of the autism that it may not benefit the person that's being tested. You may treat them in a similar way, but it may have implications for family members. In particular, Fragile X syndrome. And we would say that all patients with an autism spectrum disorder should be tested for Fragile X syndrome at least once in their life. It's either yes or no, pretty much, but if you haven't had it, you should have it, because it could have implications for family members, other females of childbearing potential that are related by blood. And if you're a carrier, a female carrier with one of the sort of bad X's, you have a 50-50 chance of passing the abnormal X to your child. So those aren't good odds. So EEG, I agree with Dr. Neumeier. You know, if a neurologist says that they rarely get one, then it's reassuring to a psychiatrist. But unless we see something that is looking like a seizure disorder, it's so difficult to accomplish the procedure that it's often not worth it. And the same is true for brain imaging scans. You don't want to have to use general anesthesia to get an MRI if you don't have to. And then treatment options. Lots of things that you want to consider before a medication, particularly if the person has never had a medication, particularly if they're younger. So sometimes people will say, well, what's the youngest age where you would give a medicine? It really depends on the severity of the symptoms. But I don't like to give a medication in people under the age of 5. Many of these medicines are FDA approved for other areas like ADHD or something down to the age of 5 or 6. So if the drugs have been studied down to that younger age, I think we all feel better. But you tend not to want to go that way unless the behavior is so severe that you just need to do something immediately. Speech and language therapy is very important for many of these people, and as was mentioned, they now have these fancy technical devices, alternative and augmentative communication, or alternative and augmentative, I don't know which one it is, which is why we just say AAC. That's why I say AAC. But those can really help somebody to learn to communicate verbally better. Naturally, you might think, well, if you try to use a device that communicates for the individual, then they'll never try to talk. But what they've said to me is, no, the device will actually help facilitate the use of speech over time. So it's really not to substitute and minimize the development of language. As a psychopharmacologist, I look at things like speech therapy and I say, well, how do you know if they're better? I'll say to the speech therapist, and they'll say, you can just tell. And I'll say, well, I know what you mean, but I don't like that, because in a medication study you have measures, you have target symptoms, and when they change that much, you're a responder. So what do you guys use as your outcome measures, before and after? Well, we don't really do that. Well, I said, well, we're going to start doing that because that's a no-brainer. And the other thing is maybe we should consider using medicines that might have pro-social or pro-language potential along with speech therapy. Because look how many people with autism continue to have significant language impairment throughout their life. 50% of people with moderate to severe autism will have only limited verbal communication throughout their entire lives. So I think we need to do some other things to try to make it work better. OT can be very helpful for the sensory needs. I think physicians, we don't know what to do for sensory problems in general. No one taught us those things, and when we do treatment studies, we don't even measure the change in sensory symptoms like, tactile sensitivity or auditory or any of that, even though the parent will often tell us that that's a major problem and contributing to behavior. So historically, people doing treatment studies we believe it, but we haven't measured change, so that's an area where we need to do better. Physical therapy for those that need it, and social skills therapy. Again, it's hard to know how effective those things are. It sounds like they should be effective. We want them to be effective, but it isn't clear that they are yet. And I think social skills training is another place where we might be able to combine that type of therapy with a medication. And then you get into academics. I mean, at some point, you're going to be faced, I'm a very black and white thinker. I don't do well with maybe or gray or any of that. I just don't, and I'm not going to change. So at some point with the child or individual, you're going to have to say, does this person need to go down a vocational life skills path or down an academic path and headed toward college? And that can be very difficult for families. But I think at some point it's in the child's best interest. You're going to have to make that distinction so you can get on with trying to help them down the path that is going to make the most sense. And then the treatment of comorbid medical problems, including seizures. We've heard a lot about vocational training. So one of the problems we're all facing is what happens after you're 22, right? So autism doesn't end at 22, although I think most people out in the world don't think there's anybody alive with autism that's older than 22. Because when I started doing autism 25 years ago, there was no such thing as an adult with autism until Rain Man came out about that time. I mean, that was a tremendous movie for informing the world that there is such a thing. And we have a special interest in working with adults where we're at, but most academic autism centers still don't see adults. We don't know anything. I just raised this the other day. I wonder if people with autism are more likely or less likely to develop dementia. Because if you have autism, you're nonverbal, you have cognitive impairment, and then you develop dementia, that's not good. We better figure that out pretty quick, because the financial, I don't want to say burden, but you know what I mean, to the family, to everybody, it's just no good, and we don't have a clue whether it's more likely, less likely, or the same. So I think there's a lot to do, particularly in the area of 22 and beyond. And then medication, I think, some of you are anti-medicine, and that's okay. I'm not pro-medicine. I'm just pro-medicine when other things haven't worked and it's clear that that's what the person needs. But I think it's fine to try other approaches first. Sometimes parents will say to me, well, how will I know when it's time for a medicine? I said, you'll tell me. You'll say, Dr. McDougall, it's time, but that's kind of the way it works. You kind of know when you need to, and it's almost like they feel like they failed if we have to put them on a medicine. You should feel that's just the way it is, Any of us can develop, somebody was talking about panic attacks, depression, ADHD. You got to treat it, right? If you had diabetes, you'd treat it. You wouldn't feel bad. You'd feel bad, but you'd still treat it. So try to get your mind around 2000 and some, whatever it is, 12 psychiatry instead of like 1950 psychiatry. So what are the kind of symptoms that we're pretty good at treating with medicines? We're pretty good at it, not perfect. And there's a lot of tricks to this, which is why you have to know what you're doing, or you can make a lot of things worse. So the first group we'll call hyperactivity and inattention. Well, right away, and this happens most often in younger people with autism, children, and if they can't sit still and pay attention, then a lot of the non-medication treatments that are occurring aren't going to be absorbed well. And many of you will say, well, that sounds easy. That's ADHD. Well, in fact, if you have a diagnosis of autistic disorder, Asperger's disorder, or PDD-NOS, you're not allowed to also have a diagnosis of ADHD. It's against the rules. It's against the law And you could say, well, my son has that. Well, that's okay. It's just wrong. So it's all just sort of the rules of diagnosis. But it's true. With the formal book, if you have a diagnosis of an ASD, you're not supposed to also make a diagnosis of ADHD. It doesn't mean they're not hyperactive and inattentive, but it means you shouldn't make that comorbid diagnosis. It's part of the syndrome. Okay, well, I didn't know that. Gee, wonder if I should mention that to my doctor. Maybe not. It's up to you, but it isn't going to matter so much. Or you could, because we want to do things right, don't we? So here we go. Motor hyperactivity and inattention. It's not ADHD, it's symptoms. And if you're going to use a medicine, what's the most effective drug to treat true ADHD, independent of autism? A psychostimulant, no question. What's a psychostimulant? There's really two categories. There's the Ritalin-based category, or methylphenidate, Ritalin, and there's other ones over here, Focalin, Metadate, Concerta, they're all Ritalin. And then amphetamine, Adderall, Vyvanse, amphetamine, that's all a different type of. Those are the most effective treatments for true ADHD. They work 70% of the time. How well do they work for the hyperactivity and inattention of autism? Not nearly as well. And I'm talking about autism now. I'm not talking about Asperger's or NOS. They often make our patients worse. How long does it take to make them worse? 1 to 2 doses. So it's not uncommon when I'm taking a history of past medication treatment. What was the first drug he ever had? Ritalin. How old was he? 4. How long was he on it? 2 doses. What happened? It just made him worse. Not always, but it might work 25% of the time instead of 70. So you need to be mindful of that, because I wouldn't expect that a pediatrician or a family doctor sort of out in the real world should be able to know that. They don't know that. So I don't blame them. They're trying to treat the most prominent thing they see. They see hyperactivity and they call it ADHD. And then they give them, it sort of makes sense, but the world doesn't do a good job yet of educating doctors or anybody else about what autism is. So we're trying to help with that by getting to the medical students and things, but it's you're sort of fighting for time, you know. So if you don't start with a stimulant to treat those symptoms, because they're very common and they can be very interfering, what do you use? My first line drug is this one, guanfacine or Tenex, usually. And these are alpha-2 agonists. These are drugs that are marketed to treat high blood pressure, so they can lower your blood pressure by turning down adrenaline. Well, if you look at a child with autism and hyperactivity, probably turning down adrenaline might be an okay thing to do. And we don't lower their blood pressure to a point that's dangerous. The main side effects of guanfacine, it can be a little bit sedating, but it usually wears off. And at times it can cause some constipation, but it's usually not going to make anybody worse. It'll either help or do nothing. And there aren't really many studies with it. One of the research groups I work with is now studying this Intuniv, which is a once-a-day long-acting form of guanfacine. It's a lot more expensive than guanfacine because the drug company still has a patent on it, where guanfacine or Tenex is generic. It's a lot cheaper. And then you could look at other non-stimulant, non-Ritalin type medicines for this symptom group. Atomoxetine, which you may have heard of, called Strattera. Bupropion, called Wellbutrin, or Zyban, all the same thing. And then the old drugs, tricyclic antidepressants, Elavil, which is amitriptyline, or things like that. So I think I talk about each of these in a little bit more. What's a good thing about the Ritalin amphetamine? You're going to find out if it's going to work or not in a few days, because you take a drug like that and you can feel it. You know, many drugs in psychiatry, antidepressants and things, you don't like feel it, right? You don't go, wow, it takes 6 or 8 weeks to feel better. These things, you take them and you feel them because it gets in and gets out quickly. So it's sort of like speed, right? I mean, in the old days, in the 60s, people would take this stuff and call it speed, or you could take it and call it a diet pill. You can call it whatever you want to call it, but it works pretty quickly. Now, what are the main side effects of stimulant? Well, they can reduce your appetite, and they can cause you to have trouble falling asleep. That's why they call it a stimulant. So you don't give these drugs later in the evening. They would be given in the morning and maybe at school or right after school. They can also cause tics. So people have referred to tics here today. Repetitive behaviors are complicated, and I don't expect you to know what a tic is and what a tic isn't, but they're different. So we have tics, we have stereotypies, we have compulsions, we have extrapyramidal symptoms, and we have the automatisms of seizures. So there's 5 different types of abnormal motor movements, and they're complicated. Tics often go in concert with real ADHD. So if you have tics like Tourette's syndrome, it's not uncommon to also have real ADHD. And the best treatment for the ADHD is a stimulant, but that can make the tics worse. So that's where that gets tricky. And dopamine is a chemical in your brain that makes tics happen. And psychostimulants like Ritalin or amphetamine increase dopamine release. So there you go. I've mentioned these can cause you to be worse. And I'd link that more with autistic disorder, lower functioning cognitively, and younger aged people. I've been using this term classical autism, and I got in trouble. I mean, you can't say anything anymore without getting in trouble, but what do you want me to call it? Canner autism? Or, I mean, there's something that's real autism that I can show you if I line up 10 people. It doesn't mean the other folks don't have impairment or something, but it's not what I think of as whatever autism is. It's degrees of severity. Stimulants you often have to give multiple times a day. So if the child's in school, that could be a hassle with the school nurse and all that. Plus, it's a controlled drug because you can abuse them. You could sell them. So we can only give you a month at a time, and you have to come and get the prescription from us, or we have to mail it to you. So you can't call in refills to the drugstore. So those are some of the pros and cons. The alpha-2 agonists I mentioned, guanfacine, Intuniv, you need to monitor their blood pressure and heart rate, but not in a over-concerned manner. You know, let us check it when they come to see us, and it'll be fine. A little bit sedating, but usually everybody can benefit from a little bit of sedation. The patient, the family, and the school. I mean, as long as it wears off, but a couple days is okay. I think that's true. And then atomoxetine or Strattera, you may have heard about it. You've heard of SSRIs, selective serotonin reuptake inhibitors. And there's a million of them. We'll talk about them: Prozac, Paxil, Zoloft, et cetera. That's the first-line treatment for depression, right, in any typical person. They're going to give you an SSRI. They work by increasing brain serotonin. Atomoxetine is a drug that's a selective norepinephrine uptake inhibitor. So it's like an SSRI, except it works on norepinephrine instead of serotonin. And it's FDA approved for the treatment of true ADHD in children, adolescents, and adults. And we're doing a controlled study of this medicine right now. Controlled means drug versus placebo, and nobody knows what they're on. A benefit of this drug compared to a stimulant is it's not going to make tics worse, it's not going to cause a sleep disturbance, and it may help mood or anxiety symptoms if you have those as well, where a stimulant won't. This is another non-stimulant, more for education, because the concern here is you never want to give it to somebody that has an active seizure disorder, because it can make seizures more likely. But I've never seen it cause a seizure in someone that didn't have an identified seizure disorder. And I use this a fair amount to treat depression in people with ASDs. It's one of the few antidepressants that doesn't cause any weight gain. People tend to like that. Tricyclics is just of historical interest. They have too many side effects. Your doctors aren't probably going to use them. They can lower the seizure threshold, dry mouth, constipation. Okay, that's ADHD, symptoms. So what was the summary on that? Guanfacine, atomoxetine, then a stimulant. Here's another one that'll get you upset with me. So the real world where you live, I think, some of you, and where I tend to not go, calls everything that's repetitive OCD. You just do. And it's not accurate. So what is an obsession? An obsession is a thought that comes into your mind over and over that causes distress. It's upsetting. It's, if I don't tap my foot 3 times, then a family member is going to go down in an airplane crash. I don't want to think it. I'm not trying to, but I can't help it. It's disturbing. So when you guys say, he's obsessed with that, no, he's not. He's into it. So most of the things that people with autism think about and do over and over are not obsessions or compulsions. They're preoccupations. They want to think about it. It's rewarding. So if I can get a little bit at a time, people change in the way the terminology goes, I'm making progress. So you guys say preoccupations. He's not obsessed with Thomas the Train. He loves it. He's not going, oh no, I don't want to think about Thomas the Train. Please help me stop. It's a preoccupation. And the things that people with autism, when they go like this or rock or jump or pace, that's voluntary. They're doing it. It's not happening to them. It's voluntary. And it's often trying to reduce their own anxiety. So that's called a stereotypy. It's hard to spell, but learn how to spell it, stereotypy. And it's not a compulsion. It's not a tic. Tics are involuntary. This is voluntary. It's not OCD. It's not a compulsion. It's a stereotypy of autism. And if you have a diagnosis of autism, you have social impairment, communication, and repetitive ritualistic. If you didn't do some of this stuff, you wouldn't even be eligible for a diagnosis of autism. So in some ways, they're supposed to do it. No, I'm not joking. I'm serious. It's part of, you should have it if you have autism. And I wouldn't view it as always interfering or problematic just because we don't do it. They're doing it for a good reason. Sometimes it can become excessive, but don't immediately try to eliminate it because you think it's unusual or because the parents sometimes parents are embarrassed about it. I don't allow that. That means you didn't educate the parent about the uniqueness of their child and why they might be doing this, okay? So I spend a lot of time on that for a number of reasons. One, because it's not OCD. And now you don't have to add you don't have to call it ADHD, you don't have to call it OCD. You're not allowed to, in fact. But the only drugs that work to treat real OCD, like contamination, hand washing, checking, hoarding, all that stuff, are these drugs, SSRIs. They're the only drugs that work to treat true OCD by themselves. So the average doctor on the street is going to say, well, guys with autism have OCD, and he's going to give them one of these drugs, just like he's going to give them a stimulant for ADHD that they don't have. And the point here is that these things can also often make the patient worse, particularly prepubertal people. That's where I draw the line. Prepubertal people, I would rarely give an SSRI to. And lots of people do. It doesn't mean that your child might not do okay with one. But when you look at the results of big studies, there's no drug placebo difference for repetitive behavior with an SSRI in children and adolescents with autism. And in fact, there's a lot more behavioral activating side effects with the SSRI. In postpubertal people, there are 2 placebo-controlled studies that say the drugs can be helpful for repetitive behavior. So you want to think about a developmental difference. But there you go. You get the point, though. You know, if they're the drug of choice for OCD, the only thing that works, and they do very little in autism, that stuff's not OCD. It's different. And I told you, say, well, what is it? I said, I told you that. It's a stereotypy. Then you might say, well, okay, what do you use for interfering rituals if they are interfering? We really don't have a drug that we've come up with yet. We're trying to work on that. We don't have a drug for the ritualistic behavior of autism that works consistently. Now, this is the one that's sort of the topic of the conference in a way. Aggression, severe tantrums, and self-injury, referred to now as irritability. And you made a good point in your opening that I often make. People will say, well, so what? So you can treat that. Well, so what is right, because it can keep you in your home, it can keep you in your school, it can keep you in your community. And it's a big deal, but the world doesn't really get that. They don't understand why treating that would be a big deal, okay? But maybe one day they'll realize it. But it can be very helpful, as you know. Now, there's one class of drugs that's the most helpful for irritability, and that's what's called antipsychotics. It doesn't mean that the patient is psychotic. It means that drugs that treat psychosis also treat aggression. And that's just one way to refer to them. The way we should really refer to them chemically is they're dopamine blockers. That's the way, remember, dopamine is that tics. So tics are caused by dopamine, and aggression and psychosis, hallucinations, a lot of that's driven by dopamine. And these anti-dopamine drugs can help in all those different areas. We're going to go through these a little bit. Now, this is the other thing to know. Drugs that don't have side effects don't work. It sounds funny, but it's true. If you're treating aggression or psychosis, there's no drug that doesn't have side effects that's going to touch that, because that stuff's real. That stuff is driven. And you're not going to get away with fish oil on that one, because how could you? You can't hit a big nail with a little hammer. It's just not going to work. So for serious symptoms, you have to use a medicine that's going to have some side effects, or you're not going to get the symptoms better. In 2012, eventually we'll have safer drugs, but it's important to know that. So these things called typical antipsychotics, these are the older antipsychotics that many of them were not even used when you guys were around, the young people. Haldol is still sometimes used, but these older antipsychotics had more side effects than the newer ones. Now, you may have heard of this term, tardive dyskinesia, or TD. What that means is slow onset movement disorder. So if you take an antipsychotic usually for a long time, and usually at pretty high doses, your body could develop abnormal movements, extrapyramidal symptoms. They're not tics, they're extrapyramidal symptoms. And they could be irreversible even if you stop the drug, but they're usually reversible. So you just say that because a lot of doctors that write these things for you won't tell you that. Not that they're hiding anything, they may just not even know or think about it. But you should know that. Very small percentage, and more likely with these older typical antipsychotics. These are the newer antipsychotics, the atypical antipsychotics they're called. These affect dopamine as well as serotonin. They're supposed to cause less tardive dyskinesia, and I think that's true, although some of them can cause tardive dyskinesia. One of the biggest problems with this class of drugs is the increased appetite and weight gain. Not all of them, but a handful can really drive your appetite and then lead to significant weight gain. And the weight gain with these atypicals is worse in kids than it is adults. But you can imagine if you have this aggressive 12-year-old and food had sort of been a reward, and he's now starving and wanting food, and you're going to withhold the reward because he's gaining weight, the behavior will pick up. So again, it gets back to this idea of, look, you got a serious symptom you're trying to treat, and it's not going to be without some risk benefit. I'm going to go through each of these a little bit. Clozapine or Clozaril, I was telling Dr. Neumeier today, I've only prescribed it twice in 25 years. So that means, and I see pretty impaired folks, so that means you guys, you probably don't need it. It's an effective drug, but among all those antipsychotics, it's the one that is going to lower the seizure threshold the most, make seizures more likely, and it can affect your white blood count. It can lower it. So, you know, your white blood count is there to fight infection. So that's not good. And in fact, you have to get your blood drawn every week or two because the pharmacist won't even give you the medicine until you show them that the white count is okay. So there's a lot of hassle involved, but it can be important to have it around if you need it, but that would be after going through lots of other things. Risperidone, or Risperdal, is the best studied atypical in autism, and it's one that was FDA approved, remember, for irritability in autism in kids. And it works 70% of the time for big-time aggression, 70%. It works pretty quickly because there's some sedation associated with it that wears off. So what are the problems? You know, it can cause increased appetite, weight gain. It can elevate your prolactin. Most of these drugs can elevate your prolactin. It's a hormone. When you're pregnant, your prolactin level goes up, and it causes women to have breast swelling and milk letdown. So you could see those two things as a side effect of antipsychotics just because the prolactin goes up. Now, not all the time, but you could see it. So look at this. The generic name of this drug is risperidone. So the trade name, you would figure it should be Risperidol. And many of you say Risperidol, at least half of you, and probably half the doctors in my clinic. But it's not Risperidol because there isn't a second I. It's Risperdal. See what I mean? That second I got dropped. These smart Nobel Prize winners at Harvard, I come out here from Indiana, and here's these Harvard, they're saying Risperidol. And I'm going, what? So I'm trying to tell you that, sort of like, don't say that anymore because there's no other I. Say it right. It's harder to say Risperdal than Risperidol, but you need to try. Now this one, olanzapine or Zyprexa, this it hasn't been studied very much in autism. It's effective, but it's one of them that can really drive your appetite and cause weight gain. Now there's people that won't gain any weight, but this one can really cause it. So you just need to be mindful of that. Because if you gain weight, then you can be at risk for other medical problems, right? Diabetes and heart disease and all that kind of stuff. Quetiapine or Seroquel, again, no real studies in autism. I sort of think of this as it's a fairly sedating medicine, which again, at times you need. And it can be helpful for a number of people, but you have to get the dose up pretty good. And you're usually going to need to take this 2 or 3 times a day. But it's a medicine that can be helpful. Prazodone or Geodon is another one. Again, not studied in autism. This is the one that's the least likely to cause weight gain, but it's not as effective. And you have to be concerned about effects on the heart. So it doesn't get a lot of use unless you had a patient that was just gaining tremendous amounts of weight on all the others, and you said, we got to try it. It'll work sometimes. Aripiprazole or Abilify is the other one that's FDA approved. The key to this drug is the only one of those pretty much that doesn't elevate prolactin, that hormone. If anything, it reduces it. The key to this drug is how you dose it. You want to start low. So if anybody's ever going to prescribe it for one of your folks, you want to start it at 1, 2, or 2.5 milligrams a day. It goes up to 30. Some people start it at too high a dose, and it can cause that restless feeling. And then you'll assume it didn't help, but you got to start it really low and go up slowly, or you're going to assume it didn't work when you just didn't use it right. Paliperidone, or Invega, it's a metabolite of risperidone. So if you put risperidone in your body turns it into paliperidone. So it's a long-acting risperidone. I have seen people respond to this that didn't respond to risperidone. So even though they're similar, there's something about it where I see differences in response that I usually don't see when it's sort of the same compound but a different formulation. This one seems to be helpful. I've had pretty good luck with it. By far, when we're talking about severe aggression, the antipsychotics, the atypicals, are going to be the most effective by far. These are medicines, many of which are anticonvulsants, anti-seizure drugs, but some of them are also mood stabilizers that you might use in bipolar or manic depressive illness, which sort of looks like a seizure thing anyway. And in many areas of psychiatry, these things can be helpful for aggression and impulsivity, but I haven't found them to be very helpful for those symptoms in ASDs. In some ways, I wish they were, because some of them have fewer side effects. But sometimes you'll end up on these, but because the stuff that's supposed to work isn't. But generally speaking, these don't do very much. So valproic acid, or Depakote, it's an anticonvulsant, but it's also FDA approved for manic depressive illness or bipolar disorder. One of the placebo-controlled studies showed the drug no different from placebo for aggression. It can cause some sedation, some weight gain. You need to have a blood level drawn periodically. Lithium, lithium is another medicine that's saved a lot of people's lives that had bad manic depressive illness or bipolar disorder. It sounds scary to you because it's been used for so long, going back to the 40s, because you might associate it with like the old mental hospital. That's just timing. It doesn't mean it's a bad drug. It's a great drug. It just happened to be shown to be effective way back then. It's a salt. It's like sodium. It's on the chemical table. So if you take salt in, you could become thirsty. So that's one of the side effects. You could drink more water, which could be another side effect. You could urinate more, which could be a side effect. It can also cause a tremor. It's not permanent. It's just while the drug. But that's usually dose related. So if you lowered the dose, the tremor would go away. And you base this on a blood level. So if you took a family history, if you had this person with a lot of irritability, and I took a family history and I learned a lot about bipolar or manic depressive illness in the family, then it would move up my list a little bit. Particularly if the other things weren't working. It can affect the kidneys, so you need to follow kidney function with a blood test, and it can affect the thyroid. But those are things you can monitor. But it's one of those drugs that's done a lot of good over time, really. Don't give it a bad reputation for any reason, honestly. Or Ritalin, Carbamazepine or Tegretol, the neurologists use it for seizures. It doesn't do much for irritability and autism, almost nothing. He has a friend called Trileptal, oxcarbazepine. For aggression and stuff, almost nothing. I'm a black and white again. Occasionally it'll happen, but not very much. Gabapentin, no, that's Neurontin. It's not going to touch real aggression. It's no side effects. It might help anxiety a little bit. Topiramate, Topamax, nothing for aggression. Another anticonvulsant. The place I've seen this be useful at times is for significant weight gain with an atypical antipsychotic. So if somebody's really gaining weight a lot, but the drug's working, and you say, I'm caught in the middle here, I don't know what to do, sometimes this can cause a reduction in appetite and weight loss, or at least stabilization. Lamotrigine, another anticonvulsant. little benefit for real irritability. One of the potential scary side effects is this Stevens-Johnson rash that could be a very aggressive rash. You'd want to be mindful of it. And then sometimes you could use those alpha-2 agonists. Remember guanfacine and clonidine? But if it's significant aggression, these aren't going to work sort of as a frontline drug. I might use this drug if I had like a 4 or 5-year-old that with aggression, no history of medication treatment. I don't want to get into antipsychotics if I don't have to. I might start here and keep our fingers crossed. You know, if a 4-year-old falls to the floor in Walmart, you can pick them up and carry them out. But if a 40-year-old does it, it's different. So size and age matters a bit. Have you heard of naltrexone? All right, so that's a wild one. That's an opioid receptor blocker, like a morphine receptor blocker. And it's been shown to help a little bit with maintenance of abstinence from alcohol. And some guys I run into across the country think it's really good for self-injurious behavior. I've just never found it to be. But it's pretty safe. But if a doctor gave it to you, it wouldn't be out of line, but I wouldn't have a lot of optimism. Okay, that's aggression, irritability. So really, you heard me say atypical antipsychotics for the most part. Mood or depression, well, this is difficult. We would assume, well, the literature would say that people with developmental disabilities have a higher rate of mood and anxiety disorders than typicals. But we don't know how to determine that, because if half the people you say to them, how are you feeling, and they can't answer you, and mood and anxiety diagnoses are based on verbal report of the person, right? I mean, you can use all that other stuff and say, but they've got a sleep disturbance, weight loss, low energy, and that all counts, but the gold standard is how do you feel? So it's challenging because you're sort of guessing. But it's okay, because I think if you had a suspicion of major depression, a radical change, you talked about changes in behavior. If you get a radical change that the group home staff says, this is not the same guy, you're not going to do much harm with an antidepressant, and you might do a lot of good. So it's tricky to have full confidence in what you're diagnosing. But listen to this. You would think that mood and anxiety disorders are common in ASDs. Maybe even, you can definitely diagnose them in Asperger's disorder because they can tell you how they feel. And they're going to present more like they would in a typical person. But there's been absolutely zero study of any medicine for treating depression in any ASD of any age in any country in the world. Zero. There's no studies. Not even a tiny one. That's pretty wild. I mean, that's just, when they say it's more common than it is in the people sitting out here, no one's even studied it. So you say to me, well, how would you think about the medicines? I don't really know. So I would probably proceed along the lines in a manner that I would proceed with typical people, because we don't really have any other idea. Bipolar disorder, we have no idea what the prevalence of bipolar disorder is in ASDs. I don't think it's any higher than it is in the rest of us. Although there may be symptoms that people diagnose as bipolar disorder that may not be bipolar disorder. So cyclical mood and sleep and aggression, that doesn't necessarily mean bipolar. But we have no studies of bipolar disorder in ASDs. What about anxiety? Now, if you guys are parents or family members or you work with these folks, 90% of you would say, oh, they have anxiety. For transitions, they have anxiety. And they do, but again, we don't really have a feel for it. I like to try to be honest. We don't. And you might say, well, what are the different anxiety disorders? Well, there's OCD. Well, we already said it's not OCD. You can't use that. There's social phobia, social anxiety disorder. I don't think you can use that really. That's like double dipping. Because you have autism, you've got a social impairment. That's the core deficit. Now you're going to say they have social anxiety? Why would you do that when you don't have to? So I don't know that that's right. So I just use non-specific terms like anxiety disorder not otherwise specified. I mean, I can't help it. I can't go with something I think it isn't, but I want to capture anxiety, or I'll call it generalized anxiety disorder. But that's the best I can do. The real issue is, can you treat it? Well, if it was you guys, you'd get an SSRI, or me, but you don't see, well, you see low-dose SSRIs third for anxiety. So I don't use them because, remember, they can make you more activated. They can increase your behaviors. It doesn't mean they won't work, but I wouldn't start with them in a prepubertal person. The two I tend to use a lot of now are mirtazapine is the first one, which is called Remeron. It's an old antidepressant that many people quit using because it's pretty sedating and it can cause increased appetite and weight gain. Well, many of the guys with autism that I treat, I say guys and I mean women too, younger people, often higher functioning, they're worried about a lot of stuff, right? Repetitive questioning, they're worried about schedule for the next day, storms, bees, whatever. And they often have a sleep disturbance, and they often are kind of skinny. So because of that, that drug sometimes lines up okay side effect-wise, because it'll definitely help sleep, and they could use a little bit of weight gain. But that's a drug I would consider if you're confident it's anxiety. Now, the key here, again, is starting dose. It comes in a 15 milligram whatever tablet. You want to start at 3.75 milligrams, a quarter of a 15. The maximum is 45. So very low and go up slowly. It also comes in a dissolvable thing that you could cut into 4 pieces of pie, you know. Okay, sleep disturbance. So as Dr. Neumeier said, this is a big problem, and there are very few studies of drugs for sleep disturbance. And this is a reasonable order to proceed in. Melatonin is over the counter, so that's easy. By the time they come to us, they've probably been through it, but not always. So it can work, but it's try it, but don't spend too much time there if it's not working. Clonidine, as she said, it's good at helping you fall asleep, but over time, a lot of the people start waking up in the middle of the night. It won't keep them asleep. Trazodone is probably my #1 drug. It's also called Deseril for sleep. You want to know that it can cause priapism. Priapism is a sustained erection. And this is something you don't think about, but it's important to. When you write a medicine for somebody that can't communicate normally, you have to think about, well, what are the side effects they could have that they couldn't tell somebody about? And that might steer you away from a medicine. This is one you have a male that could develop that. It could be a medical emergency. So you definitely want to inform the family. It's rare, but you want to be aware of it. But that can be an effective sleep aid. Mirtazapine, I wouldn't use it as a sleep aid, but only if they had that anxiety with it. The other one I've been using a little bit lately is Vistaril, hydroxyzine, yeah. It's okay. I'm thinking of one boy right now that has had, he's had all that stuff. And what I started recently, and it's working so far, is amitriptyline or Elavil, which is one of the old antidepressants, tricyclic, and that they can still be helpful for refractory sleep disturbance. Pica, I can tell you it's very difficult to treat with behavioral medicines and probably behavior therapy. I think it must be really rewarding to the person. picking up shiny, and they're fast, and you can put dangerous things in your mouth, but medicines aren't really going to help it. So I would steer that to behavioral, or maybe think about a GI issue. But now this one's tricky too. I've actually got an email right now from a guy in Providence asking me what to do. So this is where God wasn't fair, in my opinion. One of the few places where he wasn't fair. So here you have normally sexually developing people, and he didn't give them any social judgment. It's not fair. It's not fair. Because what are they supposed to do, right? We can get away with all of it because we know how to deal with all that in a socially acceptable manner. It's the same stuff. They're just doing it in inappropriate places. They don't know any better. It's not really their fault. It's our fault. So we have to be their alter ego and all of that, but it can lead to being housebound. You got 18, 20-year-old males that go to the mall and approach people. The world isn't going to mess with that. It's going to lead to law problems, arrest, or approaching their teachers, or lots of them, males and females masturbating in public settings. So you can see how it can be a real issue for the patient and the families not knowing what to do. So there are behavioral things you can do. I can tell you that SSRIs aren't going to do anything. So it's back to that idea of, well, it's a compulsion, right? Well, it's not a compulsion. It's a repetitive behavior that's rewarding. It's not like they're saying, oh, I don't want to do it, I don't want to do it, help me stop. SSRIs aren't going to do anything. And if it gets really bad, you might have to get into hormonal strategy. So I got a guy right now that 6'4", 280. And I don't know if it's hypersexuality but he's on a lot of other medicines that are doing nothing. And so I recently started him on a medicine called Provera, medroxyprogesterone. It's like Provera. Sometimes people get shots of Depo-Provera. That's what it is, except it's oral. And it can be helpful. I've seen it be helpful. You're basically lowering testosterone. This is in a male. But I'm saying it can get to the point where this guy's going to get put in jail or brought to an ER, and nothing good's going to happen there. So you don't sort of want to get into whatever you want to call it, chemical castration, but if he's on 10 other psychiatric medicines and running out the front door and stuff. So sometimes they can be helpful, but it's a big issue. You don't want to minimize it. You probably ought to ask about it, because the family may be hesitant to bring it up. Doctors are usually hesitant to ask any patient about sexual stuff. It's just not comfortable. But to me, it's like sleeping, eating, it's all the same to me. It's probably eating Campbell's soup or something. It's no different. It's just a neurovegetative symptom. They're not working with me. Okay, these are a lot of the current members of the Lurie Center, and that's the old part of the Massachusetts General Hospital. And that's my email address. Anybody can email me at any time. I'll respond pretty quickly, and I enjoy it. It's part of what I do. So, well, thank you for your attention, and we had a good time.